Hi, Dr. Rodriguez.
Hi, Alex. Nice to meet you.
Nice to meet you too.
I'm going to start muting my devices and everything like that, but I'm here if you need anything.
Okay, sounds good. Hey, Tatiana.
Good morning. Hi, Alex. Good morning. Dr. Rodriguez.
Hello. Hi, Dr. Mulligan.
Hi, how are you? Am I too early?
No, perfect
Okay.
timing.
Okay.
So I see that our session is like the fourth in a series that you've been having this month with different presentations and stuff like that. Is there something we should know? Having not attended the previous sessions, is there something we should know or be aware of?
No, actually, the 4 previous sessions, the first one we had 4 students present their different answers that were accepted. So the first week we talked about health policy. Second week it was health systems, and a third week was health economics, which actually was just last week. So yeah, this is like our big part of today is our big part of our conference. So yes, there is like this is like a wrap up, like a bigger wrap up, more than a sequence of events.
Okay, sounds good.
So we have Manuel Espinoza. He's also part another panelist. Hi, Manuel. Just to do a little bit of introduction, well, you already met Alex. Alex is part of the organizing committee from New Frontiers. And we have Dr. Daniela Rodriguez, Dr. K. Mulligan, and Dr. Manuel Espinoza. So we have a different variety. We're waiting still for 2 panelists, which I think they will be joining us in a few minutes.
Hello, everyone. Thank you, Tatiana.
Hello.
Nice to meet everybody.
Nice to meet you.
Alex and Tatiana, I looked through the notes that you had about the order of events, the sequence of events. I'm assuming that opening remarks is coming from you, right? Okay. And then we're just answering the questions, and I don't have slides or anything like that. That's okay. Perfect. Just checking.
Yeah, no, don't worry about it. We will have first some opening words by our program director. I will be the person that will be presenting. Short bios about Meredith Vanstone, that is our moderator, about the five of you, and then we will, Meredith will take the lead. And just at the end, closing remarks, and pretty much that's it. Yes, no needs for slides or anything unless you want, but it's just more of a talking kind of discussing kind of.
Thanks.
You sent us questions. Do you expect to go around and ask each person to answer the question, or are you planning on sort of taking turns and then the conversation evolves as we kind of talk to each other? I mean, if you're not the one moderating the panel, maybe you don't know how the moderator is planning on doing it.
Yes, I think Meredith would be joining us just in a few minutes, and then we can discuss that.
Yeah, she just asked me for the link. So she'll be joining in just a second.
I need to share with you a little problem that I had because there was a time change here, and so I had to schedule this meeting 1 hour before in my mind. So I had to do something at 2:15 your time. So is it a problem if I leave the meeting a little bit before? Is it too complicated? Because this is yeah, I had this. I had to.
I don't think there will be a problem. I guess by that time we will be just at the end.
Yeah, I think so. Yeah.
No worries.
Many apologies, but I thought this would be 1 hour earlier. So.
All this time difference.
Yeah.
Where are you located, Manuel?
Sorry, saying in Santiago, Chile.
Okay. Yes, we changed our clocks and you didn't, right?
Yeah.
I was just scheduling another meeting with my colleague Jaime Sapag, who's also in Santiago, and
Really?
yeah, we're doing some Pajo project together.
Right.
And yeah, I just noticed I noticed the exact same thing, that I had to change when I thought the meeting would be. I had to move it.
Right. So, well, he's my colleague in the university.
Oh, he is. Oh, wonderful.
Yeah, we work in the same department.
That's great.
Small world is.
Exciting election results y'all had this weekend.
Oh yes. Really exciting. Yeah. Very difficult.
When's the runoff? In December?
In a month. Yeah, 1 month. We're gonna have the second one. Yeah, but it's gonna be really difficult. I mean, the Congress is half and half and very extreme. So half extreme right, half extreme left. So very difficult to govern for anyone. Anyway.
Hi, Meredith.
Yes, hi, Meredith.
Hi, everyone. Nice to see you. You have a great panel that you've put together for this. Congratulations to the organizing committee and also to the panelists. And thank you for joining us. I think it's going to be really interesting.
Thanks for having us.
Thank you.
Yes, no, thank you, Meredith, for accepting being our moderator. We're more than honored about it.
My pleasure.
Yes. So Dr. Vanstone is going to be our moderator, as I previously told you. And yeah, if there are any questions, so we have a few minutes before, although we still have 2 panelists to log in. But if there are any questions, something that we can talk about, this is the time before we begin.
Would you like me to put the discussion questions in the chat so you can see them ahead of time? I don't know if the organizers circulated the questions. You did? Okay, so everybody's already prepared for what they might say. Okay, great.
So the question I had was whether you were planning on asking the same question to each of us, or you were going to sort of jump around and how you were planning on approaching it, if you wanted us to speak to each other or you wanted to moderate the conversation like precisely.
I think better if it could be more conversational. And my plan was that I would invite a different person to start with each question, but then whoever felt like they had something responsive could just sort of jump in. Does that work for you folks, or would you prefer a different approach?
Hi,
That's okay.
everyone.
Hi, Bernice.
Hi, everyone. Sorry, I'm a few minutes late. I guess it is, it's kind of hard to discern on, at the time.
Our Associate Dean of Indigenous Health here at McMaster. Dr. Downey is an assistant professor in both the School of Nursing and the Department of Psychiatry and Behavioral Neurosciences. She's of Soto Ojibwe heritage, a registered nurse, and she holds a PhD in anthropology and health. Dr. Downey has a 40-year career as a healthcare leader, educator, researcher, and consultant with a focus on Indigenous health and well-being. She holds a Heart and Stroke Foundation and a CIHR chair in Indigenous women's heart and brain health. So thank you for joining and welcome, Dr. Downey. Our next panelist is Dr. Manuel Espinoza, who's an associate professor in the Department of Public Health and the chief of Health Technology Assessment Unit. Both of these units are at the Pontifici, sorry, I'm gonna really do a poor job on the Spanish name of your university, Pontificia Universidad Católica of Chile. And Dr. Espinoza is a medical doctor and also holds a PhD in health economics. His work has focused on the development of methods and processes for prioritization in healthcare, as well as applied research in health economic evaluation. So thank you so much for joining us. Our third panelist is Dr. Kate Mulligan, who's an assistant professor in social and behavioral sciences at the Dalla Lana School of Public Health, just down the road from us at the University of Toronto. Her work aims for healthier, more equitable, and more sustainable health policy and practice. She holds a PhD in geography and works regularly with organizations such as the National Collaborating Center for Determinants of Health, the Canadian Red Cross, and the Office of the Chief Public Health Officer of Health. Welcome, Dr. Mulligan. Then we have Dr. Daniela Rodriguez, who's an associate scientist in Johns Hopkins Bloomberg School of Public Health. Her work explores the intersection of politics and public health, examining how political factors affect the development and implementation of policies, especially for vulnerable populations. Dr. Rodriguez holds a PhD in public health and conducts research and evaluations in multidisciplinary cross-cultural teams in Africa, South Asia, and Latin America. Thank you for joining us. And last but not least, we have Dr. Jennifer Walker, who's an associate professor in the Department of Health Research Methods, Evidence and Impact here at McMaster. She's a Haudenosaunee member of the Six Nations of the Grand River, who holds a PhD in community health sciences and epidemiology. Dr. Walker's work focuses on Indigenous community-engaged health research using large health services databases. She has a particular interest in healthy aging and dementia and is the co-lead of the Canadian Consortium on Neurodegeneration and Aging, Team 18, Issues in Dementia Care for Indigenous Populations. So thank you all so much for joining us. Really wonderful to have you here. So the theme of the panel today corresponds, I think, with the overall theme of the conference, which is building a better normal. And in this particular session, we're going to focus on the idea of rebuilding the plane while we fly, innovation within existing policy structures. When I saw this title, I thought it was a really evocative metaphor. It sort of emphasizes the essential nature of change, but also draws attention to our reliance on existing policy structures while trying to conceptualize and implement that change. It poses for us the tension between needing to change while also experiencing an inescapable reliance on our existing structures while we try to figure out how and what to change. One thing that I was sort of mulling over in my mind about this metaphor was that I think there's a gap here. It implies that we're trying to rebuild the same plane to get back to where we were before that plane malfunctions. Oh, is someone trying to interrupt? Sorry, I'm seeing these. Oh, yes, sorry, Tatiana, thank you. We'll move over to you. I'll just finish this thought about if we're trying to build a better flying machine, or we're trying to rebuild the one that we have, and the need to reconsider who, what, and where we should fly. And whether it would be easier and more effective to do this from the ground rather than while we're flying, and whether that's possible. So I really love the potential for metaphors to kind of open up these additional questions that we might ask ourselves. Okay, so before we turn over to the panelists, I'm going to move to Tatiana, who's going to give us a land acknowledgement.
Yes, thank you so much, Dr. Vanstone. So first of all, we will begin by honor and thanks to the Haudenosaunee and Anishinaabe nations as the traditions inhabitants of the lands where McMaster University stands, to say that it's to acknowledge a debt to those who were here before us and to recognize our responsibility as guests to respect and honor the intimate relationship Indigenous people have to this land. Thank you so much, Meredith.
And did we have anybody else who needs to speak or some other remarks?
Yes, we were just going to give a few minutes to start this event as our final panel for the New Frontiers conference. Julia was going to give us a few remarks to begin with. I don't know, Julia.
Hi, everyone. I actually thought I was closing at the end of the panel, so I could just say that congratulations to the organizing team for all the incredibly hard work that they have put into organizing this conference and getting us here to this point, this very exciting final closing panel. I have been checking into the various sessions over this last month. Each of the sessions is run on a Tuesday with various areas of focus. I think what I'm seeing on Twitter is lots of excitement and enthusiasm around this, some very, very high quality presentations. I know the faculty who've been acting as discussants have really enjoyed their roles and their contributions and the opportunity to engage with not only students at McMaster, but all of the students who have been contributing presentations to this conference. So I think very well done to all of you who've been participant speakers, contributors as faculty members, and we look forward to this time again next year. Really terrific contributions all around. And just a shout out for the program, right? As the director of the Health Policy PhD program, I think we strive for excellence in all of the work that we do. And I think this event is a good example of that. So with that, I'll turn things back over to you, Tatiana, and really excited, really excited about this final panel.
Thank you so much, Julia. Thank you for being here and for your kind words. So now, Dr. Vanstone, thank you.
Okay, thank you. It's like the advantages and the challenges of Zoom. The advantages are that we get these guests from all across North America, and the challenges are sometimes we're a little bumpy in terms of the order of things. So I apologize for diving right in with and skipping the important opening remarks. In any case, we've introduced the theme, we're rebuilding this plane, we're on it, we're flying right now. And I'd like to ask each one of the panelists for some brief opening remarks on what the theme of this panel about rebuilding the plane while we fly means for your particular area of research. So maybe I'll ask Dr. Downey to start off, and then if anybody would like to jump in after that, you can. And if we have one of those famous Zoom awkward silences, then I will nominate a second panelist to go after that.
Well, thank you, Meredith. And I'd like to extend an overall thank you and appreciation to the organizers for inviting me to participate on this panel. I thought the analogy was a provocative one as well. And just kind of gave me pause to think. Sometimes when you're down in the weeds with your particular area of focus, it's nice to just have a moment to step back and think about how you might explain it. This is an academic exercise, but still it's also an opportunity to just have some informal dialogue. And so I appreciate that opportunity. I think it's, really relative to the work that I do as the Associate Dean Indigenous Health. And as we are embarking on the implementation of our Indigenous Health Education Learning Lodge here in the Faculty of Health Science at McMaster, we are trying to walk a different path. And that is, one that is aligned with and in keeping with principles related to reconciliation with Indigenous peoples. And I see this, as something different that we all need to consider, and yet at the same time, something unique that can tie us all together, because reconciliation is not just about Indigenous peoples. It calls on all society, all mainstream society to participate. And that is a different approach from one that we could apply to other situations. So, I think it's an opportunity today to share a few thoughts about what we are trying to achieve and how it relates to different areas of policy. And, I sometimes used to think and have thought over the years that I should have done my doctorate in health policy for Indigenous peoples. And when I thought about preparing for today, I was reminded of that. And I think the number one reason why I didn't is because there were no Indigenous faculty that could mentor me. And I wanted to come to McMaster. And so I was thinking about that again today, because a lot of the work that I do, we have to address policy sometimes at all levels to do that. And without those mentors to pass on their wisdom and knowledge, you have to rely on outside sources or just, fly by the seat of your pants. So anyway, that's me. And thank you once again for the invitation.
Did you say you want people to just come in? Because
Yeah, go for it. I love when people just jump in.
Okay, jumping, not from the plane, onto the plane maybe. So I think there's two things that I wanted to say just in a bit of an intro reflection. And that is like this analogy of rebuilding the plane while we fly. I think about it in two ways. One is that there are processes in Indigenous spaces, Indigenous policy spaces, of both decolonizing institutions and processes and policies. So this idea of decolonization, and there's also processes of indigenization, which is, in my mind, building something that is based on Indigenous worldviews and perspectives from the start. So when I think about rebuilding while we fly, I'm thinking about both of those processes, both the process of decolonizing, entrenched systems and policies and structures at the same time as Indigenous-led indigenization efforts that are based on Indigenous perspectives and worldviews. And I think both of those things are important. The other thing that I think about when I think about this analogy is actually another analogy that someone said to me recently. It was in the context of artificial intelligence and this idea that the train has left the station. Like, Indigenous people better get on this train because it's left the station. And this general feeling like sometimes you have to land the plane or stop the train and think first. Like, maybe we don't want to rebuild the plane while we fly. Maybe that's not safe. Maybe we do need to land the plane for a bit and really think and stop and take stock and really make sure everyone's on the plane first before we rebuild it while we fly. So I guess this this theme is really, it is provocative. And I think, I rail against it in some ways, because I'm just like, sometimes we just need to stop and take our time.
So I come at this from a slightly different perspective, right? So if I think about sort of the three main areas where I work in health policy, I work in evidence use in informing decision making, and then thinking about equity in vulnerable populations, what I refer to as politically vulnerable, right? Not just because you're a woman and child, but because you're politically vulnerable because of behaviors you engage in. Maybe you exchange drugs for sex, or you are ethnically or an ethnic or religious minority that makes you politically vulnerable. And so the sort of in those particular areas, things that I'm seeing that are going to need rebuilding of the plane as we go, and I don't know how we do it, and I don't know how we stop the plane to make it happen either, is on the evidence side. I don't think public health is equipped right now, both technically and in terms of human resources, to handle the amount of misinformation that is going around, both at an individual level and at a massive level. We just don't have the capacity. And part of it is that the field of sort of how we understand misinformation and technology and whatever is moving beyond our general capacities, but also we just don't have the warm bodies to like fight, nor do we necessarily know the right strategy. So I think that's going to be an issue. The second part around policies is that what this pandemic has demonstrated is that our policy and governance metrics and indicators and the way we measure those things, they failed us. So many of the metrics that we had about a prepared government or a prepared society or prepared and resilient health system have proven themselves to be quite limited when the actual rubber hits the road. And so what it seems to me is that one is that it takes a reflection that all institutions are subject to politics. So even the best prepared institution, the best prepared government, I think we see that playing out all over Latin America, not just in North America and Europe, but you see it playing out all over America in places that were supposed to be prepared and have a decent social safety net, didn't do very well at all when it came to actually caring for people. And then the third bucket that I see is around how, somewhat predictably, if we continue to ignore vulnerable groups, they will, as a matter of fact, be disproportionately when vulnerability is a huge contributor to illness and disease. And so then we have to build the health system to reach them as the house is burning down around us, instead of making the effort to try to build a system that reaches the most vulnerable all the time, that is then equipped to reach people in terms of crisis. And to me, in particular, that last one is the kind of lesson that you feel like you're sort of saying it for, sort of so many of us have been saying this from the outside for the longest time. If you build health systems for the lowest common denominator as opposed to the hardest to reach, you're never going to reach the hardest to reach. And this has been a really acute and horrific lesson in how that plays out, but how we then change mentalities to sustain the things that we've learned, the strategies, initiative approaches to reach the hardest to reach. That's the part that I don't know that we have an answer to, because often the problem is we don't have money, or we don't have structures to keep this going, or realistically, so many people are just burnt out in terms of all this work. I feel like perhaps this is a bit of a Debbie Downer outlook on this theme, but I don't know. I look around and I feel like there are some things, there are a number of our, at least in my field, a number of our policy and public health gods that have been knocked off a few pegs. Over.
So I'll jump in there. I do my work from a bunch of spaces, but primarily trying to directly intervene in policy. So for example, I'm a public member of the Toronto Board of Health. And so I have some direct experience with both the opportunities and the limitations of rebuilding the plane while we're flying. Like, we have had to meet emergency needs, but there are some broader systemic and transformative changes that we also need that we haven't been able to do. So, I've spent the better part of the last year really thinking about this question in terms of what do we need going forward if we did have that opportunity to do something really different. And, so here are some of the things that I've learned that I think I want to share that I think are important. One is that we need to invest in healthcare and social care at the neighborhood level, at the level of local communities. And we've seen some excellent examples of that here in Toronto, where public health and healthcare eventually, not right away, saw the leading work that community organizations were doing and started and invest with them. And then we started to see better approaches to mobile and pop-up clinics in the communities that need them most, culturally safe and appropriate services, buy-in for Indigenous people, those kinds of services starting to emerge and be resourced in a way that they weren't before. That took time and it took a ton of energy, but it's different. It's something unique. And I think really, really globally leading work is starting to happen in those partnerships. Second, we have to be accountable to these communities for their leadership, their knowledge, their expertise in setting priorities and in doing this work. There is a ton of capacity in communities, but it needs to be respected, resourced, and integrated into decision-making. And that's where things like having public members of a board, not just politicians, is an important step, and how we need to keep thinking about how to do that in a way that really represents the most impacted communities who are facing the biggest equity barriers. So third, collecting and using data that helps us with equity, right? So for example, using sociodemographic and race-based data, which again, we were not doing early on in the pandemic, but started to happen over time and is reported out now in Toronto and has helped to demonstrate where the need is, to invest appropriately. And again, we still have work to do to make sure that these data are governed safely and appropriately and accountably. But we've made some progress there during this time. And then the last one I'm going to mention is that the longer term piece, which is in addition to these fixes that we've been able to do along the way, we do have to dismantle old systems that perpetuate health inequities. And we need to look more closely at their histories. And so when Dr. Walker mentions colonization, for example, the roots of colonization, racism, eugenics, and so on in our health and public health histories have to really be acknowledged so that we don't just assume that social determinants are somehow inherent, but that they come from somewhere, and just as they've been built, they can be unbuilt. I'll leave it there for now.
I'm going to jump in. Hello, everyone. Thank you very much. Hard to speak at the end after bright people. Trying to say something smart here. Well, I work in health economics and outcomes research and methods for health technology assessment, i.e. informing funding of new interventions or technologies in healthcare and priority setting, mostly in middle income countries. So I'm going to take this position to answer this question. When I studied health economics and my PhD in York in the UK, I contributed to the development of new methods to explore heterogeneity in mathematical modeling and prospectiveness analysis, and in the setting of the UK or something similar in Canada or Australia. However, when I was back in Chile and Latin America, I realized that we needed to adapt those methods to the local reality. For example, I had to work for the Inter-American Bank of Development in Dominican Republic to update the National Health Benefit Plan in 2015. We needed to implement a priority setting process to update the plan using a very simple methodology that was proposed by the Ministry of Health. However, during the deliberation with different stakeholders of the country, we realized that the methodology wouldn't be enough for the purposes of the country in terms of legitimacy, because the method was quite weak in our, we thought that at that point, that was our analysis. Well, another alternative would be to adopt the methods used in the UK or Canada, using cost effectiveness analysis and clinical evidence. But we knew that using this, it would be complicated or almost impossible given the lack of data and lack of capacities in the public sector in the country, in the Dominican Republic. So we thought that relatively new methods in healthcare, multi-criteria decision analysis would be the best method at that point in time. That was our judgment. However, it didn't work either. Not because the methods were bad or useless, but because of some internal political fights and problems that different stakeholders of the country they were having. I'm still asking myself that maybe if we implemented the methods they propose, the exercise would have been more successful than we actually haven't. But in contrast, now This year in Argentina, we are implementing exactly the similar exercise with the Ministry of Health. We are applying MCDA, multi-criteria decision analysis for priority setting, for a new national health benefit plan. And the experience is quite different. Now, the method is not totally new for the stakeholders. People know what we are talking about, and they have participated in a fantastic way. My point is, in 2015, 6 years ago, we probably made a mistake proposing the use of this very new method, more sophisticated, in a jurisdiction that was not available to follow that approach. Therefore, the use of methods without a clear understanding of the political and organizational context, the local objectives, the local inertia to innovate carries the risk of failure. In other words, we always need to rebuild the plane while we fly, according to the local context.
Thank you so much. I think a wonderful introduction to the expertise and the passion that each of you bring to your work. So for the following questions, I'm going to invite one panelist to start off, and then whoever of the other panelists have something to add, please jump in, respond, but we won't feel the need to go one by one for these questions. So feel free to sit a question out if you feel like it's not something that you have a burning response for. So I think that for the second question, we're going to start off with Dr. Rodriguez as our first respondent. And this question is, in your own work, what policy structures set important parameters for innovation? And what examples have you seen of creative change within those parameters?
Parameters for innovation. I mean, honestly, structures and institutions don't do well for innovation. I mean, I know that's kind of a generalized, like a kind of a blanket statement that maybe isn't quite fair, but institutions are institutions because of their legitimacy, but also their weight, history, and baggage. And so that makes it very difficult to I think, innovate successfully. My guess, but what I would say is some things that I have seen that I think allow for questioning, which I think is a precursor to innovation, are, for example, I'll use an example I've seen in Mexico, and there's others, where large programs, large reforms require evaluation. There is some proportion of the investment that needs to be spent on evaluation and trying to understand, implementation, research, effectiveness, all of that, impact, all of that kind of stuff. Setting aside whether the evaluations are any good or whether there is any kind of politics that get involved there, that's setting aside that. I think just having that as a parameter to say, we are trying something, we are pretty sure it's not going to work entirely the way that we want, and so we want to learn from that. And then institutionalizing a mechanism, resources, and a demand for there to be learning, I think sets a precedent that is very different than when you do whole-scale reforms or you implement whole financing schemes, or say we're going to magically open all of these primary healthcare centers and don't actually try to do any learning about what happens after the fact. And the fact that this is coming from the government, and the government is setting aside funds to do this, means that is a commitment even from government institutions. So I think that sets that creates opportunity for innovation, but I think it can be very difficult if I think of policy structures in particular as they relate to government and development partners that are associated with governments. It's very difficult to think about structures being a good place to foment that kind of innovation and change. I will say that I am mostly cynical when it comes to a lot of this stuff. So, other more sort of positively oriented people should chime in as well.
I'll chime in and say that, one area where I do think that policy structures are setting some important parameters is when they are structured to be inclusive of community. Tons of research just shows that, resilient systems are those that are very adaptable to local leadership and local feedback, that have structured this in. And we certainly saw where that didn't happen, what the impacts were. right? That, you know, most of our emergency management that we really had to rely on in those early days of the pandemic did not include community at all. In fact, our board of health didn't even meet for the first many months of the pandemic, relying on existing emergency systems and services to just kick in and do their thing. That's not what we want. And over time, we've been able to take a breath and think about that and build and grow. And that's just, you know, that's just health promotion 101, improving the capacity of people and communities to take a bit more control or a lot more control over the conditions for their own health and well-being. And so in places like community health centers, Indigenous primary care teams, other community organizations, we see a little bit more flexibility and adaptability within their structures and at that local scale to take the kind of action that's necessary, even under extremely challenging circumstances and not particularly sustainable circumstances. They're doing what they can to meet the need. And so, you know, that's where I see some potential to wedge open a bit more space in the policy sphere and in terms of institutional structures for self-determination, to help people demonstrate their autonomy, their assets, their competence, right? And how their sense of belonging is part of the contribution that they're making, and how they do have the capacity to give back and the expertise. And the institutions have yet to fully find ways to value and leverage and connect to that.
Great, thank you. Maybe we'll move to question number 2 then, and I'm going to ask Dr. Walker to be our first respondent for this one. So this question is, what challenges do you see or have you come across in using equity as a value to drive change in policy?
Thanks so much. So I'm going to obviously be coming at this from a perspective, an Indigenous perspective, one Indigenous perspective, and that is that when equity is used as a value to drive and change policy, sometimes that undermines the hard work that Indigenous nations have done to strengthen their self-determination, sovereignty, those rights that are in the United Nations Declaration on the Rights of Indigenous Peoples. These sort of a rights-based thinking and acknowledging the sovereignty of Indigenous nations is quite different than seeing Indigenous people as an equity deserving group or equity seeking group. And I think that that really gets washed out in many equity initiatives. So, you know, not to undermine equity initiatives, but I think that there needs to be an understanding of self-determination and sovereignty. So those equity initiatives can't undermine sovereignty. So there's very few places where I've actually seen these things working well together, but I think that's the whole area of work that we need to do to really understand that intersection, so that there's, you know, that equity initiatives don't undermine sovereignty and sovereignty doesn't undermine equity initiatives. So I think that that's, from my perspective, one thing that I wanted to say. The other thing is that when it comes to, actually, I'm gonna stop there. I'll leave it there and see what other people think.
Yeah, I can jump in there to reaffirm what my colleague, the important point that she mentioned. And I spend quite a bit of time these days because I find that the equity, diversity, and inclusion environment right now, there's a lot happening. And I find generally institutions, organizations that I interface with are struggling to, you know, with the age-old question of how are we supposed to be all things to all people? And I find that statement in itself has been a barrier, attitudinal barrier that has been in place for many, many years. And so I find it promising that, you know, that this kind of context is happening right now. But as my colleague pointed out, it can also be quite challenging. And, in keeping with the analogy of the flight, the aerodynamics, I'm thinking that we're not all heading to the same destination. And so it might be this context of equity and inclusion, but Indigenous peoples really are seeking a more self-determining approach. And so I was a participant to a WHO initiative on social determinants of health, and I was able to participate on the Canadian reference group that supported the Canadian commissioners, who were the Honorable former Health Minister Monique Bégin and Stephen Lewis. And we held an international dialogue on the social determinants of health. And it was affirmed at that meeting from Indigenous people around the world that we were not so much seeking inclusion, because the commissioners were classifying us, grouping us under a social exclusion framework. And so Indigenous voices at that meeting said, we are not so much seeking inclusion as we are seeking self-determination. And, we asked for a whole chapter so that we could, articulate this more carefully. We got a text box and basically that said, two critically important social determinants for us was land and self-determination. And so I find almost 20 years later, the uptake on those two very important social determinants has been lost in trying to achieve this equity for all. And, even more recently, locally in our Code Red project that has received national awards at the 10-year report card of that initiative, it was noted that for some populations, culture remains a very important social determinant of health. So there's no uptake on self-determination and land in this, in that example. So I think that, I don't use the term BIPOC. I respect it because of, community solidarity and, and because Indigenous peoples, Black people and people of color have come together, perhaps strength is in numbers. But I think it's a very targeted health equity approach. And, I aspire to achieving that through our own cultural, our own Indigenous ways of knowing, which are very diverse among different groups. And so anyway, so I just wanted to share that. I think it's one of the key important areas to think about in our health equity environment.
I'm going to jump in to contribute with a slightly different perspective, because the area I work is economic evaluation to inform funding of new health technologies, where equity is a major concern. For all of you who are familiar with the framework of cost-effectiveness analysis, you know that it's anchored in a health maximization principle, regardless who gets the benefits, who gets the health. However, in policymaking really matters who gets the benefits. Actually, the society would be more willing to give priority to some subgroups of the population, for example, less advantaged people compared to others, more advantaged, for example. But it's not just only about who gets more or less benefits, but also is about because this is the problem of resource allocation, it also matters what are the distributional consequences in the general population, those with other diseases who are also demanding health care, the problem of the opportunity cost of the resource allocation problem. This problem is usually addressed through deliberative exercises appealing to value judgments of different stakeholders. But usually stakeholders look at one part of the equation, the benefits, who get the benefits, how they distribute across this population that we are looking at, without the concern of what is happening in the general society as a consequence of the diverting those resources to one group of disease people with some particular disease. Who bears the opportunity cost in the general society is also something that matters in our equation. However, in many countries, in addition, let's say, in many countries, these committees of experts are not totally legitimate, which is another problem. Hence, there is an institutional problem where participation and fair processes must be enhanced. There are other instruments now to facilitate this discussion, and there are new methods such as distributional cost effectiveness or extended cost effectiveness analysis. The main barrier here is the access to data needed to populate the mathematical models we use. But we are working on that, and actually in Chile we are developing the first this type of models and this type of information to facilitate the discussion. But my point is, remember the two sides of the equation: benefits, distribution of benefits, but also the opportunity cost of an alternative use of those limited resources.
So I wanted to, I primarily work in international health, but the last 2 years, in part because of interest in relationships, but also because I've been grounded, like so many of us, I've been working more and more in Baltimore City, which is where I live. And I had started engaging with an organization that's focused on health for Latinos in Baltimore, and have been working more and more with them the last couple of years. And the majority of the Latino population here in Baltimore City are migrants. And I would say most are of mixed documentation status, or they don't have sort of full residency status. And so, sort of thinking about this equity issue here in the city, when you look at the proportion of the population that Latinos prior to all of this represented, it was a relatively small proportion compared to the largest, what you would refer to sort of as people of color group, which was Black Baltimore residents. Black Baltimore residents is a majority Black city. Okay. So because of that, the health department and so many of the city resources were focused on serving primarily that population because it had the greatest burden of disease. And that makes sense from a strictly kind of numbers perspective. This is a large group. They're disadvantaged in all kinds of different ways. They have all kinds of different needs. And from a health department's perspective, which is, when you have a limited budget, you spend it where you think the highest burden is. So that blew up in everyone's face when COVID happened, because the greatest impact was around Latinos. They didn't have stable housing. They were in mixed household conditions. They were day laborers, so they're still showing up to work. And so by the time they were showing up to care, they were severely ill and even dying in the hospital. And this point about like we didn't have data about what was going on. Doctors are saying these people are showing up in the ER and they are really, really sick. And so it meant that the health department had to pivot to serve this population in a way that they never had before, that they didn't have really the capacity, just like the bare minimum language capacity to do before. And in the subsequent year, they have done unbelievable work. But from my standpoint as an advocate for that population, we shouldn't have been that far behind. Like the learning curve shouldn't have been quite so great. And the sort of reliance on community organizations makes sense, but the over reliance on community organizations is not only untenable, but unfair, right? So I think one of the challenges, though, if I'm being, I think one of the challenges that the health department faces with this particular population is legally, there are very few things they can be offered. There are very few services that can be offered to them for free or low cost. There are very few things that they can, very few social safety nets that are available to that population. So if you're a health department that has a limited budget, the government for various means, in particular, prior to the Biden presidency, has made it very complicated to serve this population. I can, from a very rational standpoint, understand why you wouldn't just either, not actively make the choice. And so I'm glad to see that they have responded and they recognize that there's a need there. And there have been, there have been structures that have been built and all this kind of stuff. But the challenge is that in cities like this one, equity is a really complicated word to parse out because it's about equity for whom? For the largest part of the population that is vulnerable, for the people who are most suffering for this issue right now, for the people who are oppressed by the legal systems that exist that prevent them from getting basic services. I mean, it's extremely complicated. And I think that's one of the issues that gets obscured when we talk about equity. And I'm fascinated to hear from Dr. Downey and Dr. Walker about the perspective that Indigenous communities might be bringing to this. We have a very small Indigenous population in the city, but I could definitely see them potentially bringing the same perspective of we're looking for something different. So I appreciate the perspectives of the panel on this. Over.
I'm just going to jump in with one quick thing, which is that I actually interpreted the question a bit differently, Meredith, when you posed it. And I was thinking about, what are the challenges in using equity as a value rather than equity as an approach or as a measurement or something else. And so, for me, that's been an important part of the work in trying to speak to policy and decision makers, that we can't just use the language of values or what we consider to be fair or unfair when we're trying to speak to them. And this can be difficult for communities and advocates and others to accept or to engage with for lots of good reasons. And one of the challenges that we have as researchers and as interveners in policy processes is learning how to not be knowledge translators, but help to be interpreters between communities and professions and sectors with really different ideas about what values are informing their work, what constitutes evidence by which we need to make decisions or guide our work, and so on. And so we, using the data and the expertise that all the folks around this panel have is a really important part of the overall collective movement toward more equitable conditions, differentiated in different ways by and for different people and populations, but in a way that, where possible, we can measure so that we can point to that. And, it sort of goes back to that idea around epistemic justice, the justice of being seen and heard and being believed. And for, it's not like Indigenous, Black, and other communities did not expect that they would be impacted when COVID happened. They knew, and they weren't necessarily listened to, especially early on. But the data spoke. And, that's unfortunate. I think there are other things we need to do to improve epistemic justice and ensure that people are heard, at the same time as using data to help those voices be heard and help those stories be told in ways that are meaningful to decision makers within systems.
Thank you all so much. Those answers were so rich, and I appreciate how you all brought different perspectives to bear on this question, and the metaphor that you left us with, Kate, of the policy work as work of interpretation between groups or communities that might be using the same words to talk about different things or have different priorities, and the policy work as the sort of the bridge building or the interpretation between those two groups. For the third question, I'm going to ask Dr. Espinoza to respond first. And this question talks about policy intervention as happening at multiple levels, from communities to entire countries. And what level do you work at, and how does that affect your relationship with existing policy structures? And then after you give a response, invite the other panelists to jump in if they have something to add.
Thank you very much. Well, in my work in the university and as a consultant of the United Nations for the Office for Project Services of the United Nations and the Inter-American Bank of Development, I've always been working at macro level in the health system. So in the university, I lead a research unit where we produce pharmacoeconomic studies to inform whether national insurers should pay for a new technology. We also run methodological research to improve the current decision-making processes, as well as qualitative research to incorporate social value judgments and participation of different stakeholders to enhance our current processes. in Latin America, I've been working on HDA, building capacities for HDA and economic evaluation and priority setting also at the Ministry of Health level. So economically speaking, this work has been focused on a demand side, payer, ministry. But I haven't had the opportunity to work much on the supply side of the health system. This have offered me the opportunity to build a broad network with many policymakers across the region, which has been a very, very satisfactory experience with the existing policy structures across the region. So I used to work with people who's now in the Ministry of Health and who's tomorrow in the Ministry of Health, like Tatiana, for example. I met her when she was one of the leaders of the Ministry of Health in Ecuador. And now she's here. So the network goes and comes. That is a fantastic, fantastic opportunity. Thank you.
Anyone else have anything they'd like to say about the level that they work at and how that affects their relationship with policy structures? Yeah, Dr. Walker, I can see you've unmuted.
Okay, thanks. Just one thing that I wanted to say is that I think that I work at multiple levels, multiple levels for policy structures, I guess. But what I wanted to say is just that sometimes one thing I find, you know, there's this health policy course where every year I teach two classes within it to help orient people to how Indigenous health policy is developed. If we honestly respect the sovereignty and believe that we have Indigenous nations with self-determination, then we have to honor those processes for policy development as well, and not think that policy happens outside and is imposed. And so what I noticed in doing those classes is how little is taught about Indigenous policy making institutions and policy structures. So community level, regional level, national level, how do First Nations policies get developed? How do they get received? How are they influenced? How are Government of Canada policies influenced by all those levels? And so I think that that's something that's that we really, as we rebuild this plane, helping people to understand and really embedding that like in our courses and in our understandings of health policy is that how does that, what are those decision-making institutions and policy institutions within First Nations, within Métis nations, within Inuit communities that drive those policies. And so I think that I just wanted to say that so that there's an acknowledgement that there's a parallel structure.
Yeah, I think I again reaffirm my colleagues' perspective on this and would say that in my own career, you know, engaging at all levels from the local, regional, national, and international levels at some point or another has been really critical to trying to influence policy change. And, you know, I think that in the area of Indigenous research, for example, you know, we can draw on the more than 25 years of experience among our Indigenous research community here in Canada, who have established these relationships at the local, at all those levels. And so that interface can support and perhaps influence policy within one's own domain. So we have, you know, we have seen examples of local or regional Indigenous communities who go right to an international forum to shine a light on their particular circumstance. And in that case, sometimes the outcome is the light of shame on the member state for those, you know, conditions existing in their country and can lead to, you know, influencing policy and decision making. And so I find researchers collaborate at those international levels. I've learned a lot from working with Indigenous colleagues around the world. I also just wanted to make the point that, you know, a lot of times an institution is very invested in engaging as a good global citizen. And, you know, I have had the opportunity to participate in some of those global health or global research discussions. And I often try to relay that, you know, often, at least for Indigenous peoples in Canada, that we are, you know, dealing with, challenged by, you know, living conditions that can be classified as third world here in the country. So I often use the term of the glocal, and, you know, how this global citizenship work applies, you know, can be applied, you know, with a sense of urgency to what's happening within our own country.
Thank you. Thank you so much. For our next question, I think we'll ask Dr. Mulligan to respond first, because I really heard some resonance with your comments and your responses to the other questions, and with the formulation of this question. So the next question is, what relationships do you see between top-down policy change driven by formal decision-making processes and bottom-up change driven by the grassroots?
Yeah, so I mean, I'm a health geographer, so I love all those questions about how we do things at different scales and across scales and so on. And of course, like my colleagues have mentioned, we really need both and. Here in Canada, decision makers are notoriously cautious and small c conservative about making decisions, about doing anything differently, about making any kinds of changes. And so one thing that grassroots and local level action can do is just demonstrate that kind of made in Canada or made locally or made by our local community approach, even if it's an adaptation of what's happening internationally or globally. So some of our own work about social prescribing in Canada, for example, learning from how it happens in the UK, but making local adaptations for the Canadian context or the Ontario context or a particular municipal context or a particular community, neighborhood, and so on. All of those help to build the confidence of Canadian decision makers. And that, from my perspective, that's one of the most important ways that we use evidence, is just to reassure them that it's not going to be overly transformative and radical to make the change, which is unfortunate because there are lots of times when we do want to see much more transformative change. But when we're doing that policy work, we want to be reassuring them that what's happening is feasible, affordable, and something that they won't be sticking their necks out too far about, and so on. So that's where, you know, community driven and community informed policymaking can bring the savvy, the expertise, and the knowledge of trying things out locally to those other scales where decision making happens. And that means that the policy work is in some cases just ice breaking, but, you know, creating a path for the communities and their knowledge, or the knowledge coming from small pilots and things like that, to really scale. Oftentimes we get stuck at that small pilotitis and we don't get to scale. And so that's where we really, really need that distinct policy intervention to make sure we don't get stuck there. Because the constraints at the grassroots level are not in cautious thinking, not in conservatism, but really just primarily in resources, and not being structured into the system in ways that are effective and meaningful for them. So learning from the willingness of grassroots to roll up their sleeves and innovate and try things out, and shoestring and all that stuff, that's all really important learning that we can feed forward and, you know, over time, hopefully change those bigger cultures alongside changing their policies.
Dr. Downey, you had your hand up. I wasn't sure if you wanted to go first.
I think I just forgot to take my hand down, so I will lower it now.
I just wanted to chime in. So I agree with everything Kate has said. I would say that one distinction that I would make, and I think this is important for I'm assuming we have students on the line, for students to remember, is that there's big P policy and then small p policy. not all policy making is created equal. So it is very difficult to do major health sector reform bottom up and have it be like, and not have it fall apart somewhere along the line. But it can be extremely effective to have, and I think of, and I'm going to distinguish here between there's sort of community, the way we think about like people living in your local neighborhoods, however you end up defining your neighborhoods, as well as the people who work in the health system at your local level, right? That kind of bottom up policymaking. That's where, you know, you really see some really interesting stuff going on in the way that people that work in the health system or benefit from the health system interpret the rules and guidelines that they've been given to best work for the local population, assuming that they're well-intentioned and all of that, right? And so that I think can be, if you're thinking about different types of policies, they're just better suited for certain types of decision-making. And I recognize that perhaps that distinction perpetuates the ability for policy structures to say, we should continue to make the decisions on our own. And that is not good. But I do think that there is something to be said about if you want wholesale change, and in particular, if you're thinking about totally shifting the way a health system or an aspect of health system is resourced, organized, who they're targeting, those are realistically big, higher level, big P politics, you know, budgetary kinds of decisions that are very difficult to kind of implement. They're very difficult, can be very difficult to influence from the community side. Not that they shouldn't be, but they can be very difficult.
Can I just contribute? So I think interesting question. An important issue here that's in the area I work is the paradigm based on which decisions are made. The classical top-down sort of decision-making process in healthcare are mostly supported by a positivist paradigm. In particular, decisions about changes in the health systems involving new resources are mainly driven by evidence. So in HTA, evidence-based medicine, economic evaluation is the evidence. However, when we include for example, patient representatives or representatives of civil society, they are usually not applying this framework. That, for us, is quite reasonable and standard. In a study that we developed here in Chile, we call this the paradigm crash, because the funding of high-cost drug that we have in Chile, we have patient representatives and classical experts in the same group of deliberation to make these recommendations. What happened is that patients started studying evidence-based medicine, economic evaluation, and they wanted to become experts, clinical epidemiologists or whatever. So we've been working in the last few years on trying to reveal what really adds a patient representative or what really adds a civil society representative to these spaces of decision-making. They shouldn't be experts. They should value the additional benefits that a particular technology provides to the population or to a particular group of sick people. But they shouldn't become experts in a positivist way that we have in mind, medical doctors or economists. So this social-cultural paradigm, including tacit knowledge, communities of practice, hasn't been yet incorporated into any decision-making process. Even in countries like the UK, Australia, that they have patient representatives, sometimes they call the patients, they go for just having a cup of tea or eating cookies, just to sign the list, but they are not really contributing to the deliberation process. So I think these are really important elements in jurisdictions that are continuously changing because of how the structure of the society changes because of immigration, globalization. The values of the society are dynamic, and they should be in these spaces of disease, of decision. Sorry, decision. Thank you.
Can I ask you a follow-up though? So
I'm going to add
why-
something too after you, Daniela.
So I'm curious about why you think that the patient representatives felt that they needed to sort of become experts. I mean, is it a question of sort of feeling like my interest is genuinely piqued and I want to learn about this? Or is it I'm in a room where my voice is not sufficiently valued unless I can kind of drop these codified forms of knowledge in order to be able to be heard?
I think the last. I think they believe that they need a language to communicate with the rest of the experts. Well, and the other thing is because these panels, these groups are, 10 people, 2 of them are patient representatives only. So, it's not balanced with the general community. So they don't have any other chance to participate that, incorporating the language.
So do you have a sense about whether that the sort of, what did you call them? I think classical experts in the room were, like how did they interpret that change? Because I would think that one of the efforts that can be made is to work with the classical experts and to say, you need to learn what they're talking about instead of necessarily having the patients learn to try to accommodate the so-called experts.
Well, absolutely. I totally agree that is not very easy with experts. So that's the second part of our work, but still working on that. Yeah.
Okay. Thanks.
Thank you.
I just wanted to add one thing, which is that, even within positivist frameworks and paradigms, we have sometimes really terrible indicators. Like we're measuring things and that might not be the things that are important to be measuring. In Canada, there's a huge focus on measuring volume, right? How many people are shunted through the system? How fast can we get people through? Is that relevant to what communities think is important, or even what the evidence shows is going to actually make a difference for health outcomes, health services usage, health equity, and so on. So I think that even within those frameworks, we still have work to do to really measure what's important to us. Following the example of well-being budgeting, for example, think about benefits that accrue outside of our line item or our management unit or our department, and think more broadly about how to measure and capture the benefits of things like social interventions, health promotion, and all that other kind of work that gets past the straightforward indicators, simple clinical indicators sometimes that health organizations' progress is measured against by their funders.
Which incidentally, we do what we're measured against, right? We don't go beyond what we're measured against because it's already complicated enough to do the things that we're measured against. So I think the evidence is not neutral. Indicators are not, gods. There need to be questioned how they were developed and what we do to try to meet them. We then shape our institutions to meet those metrics in a way that is, especially if we're not looking at unintended consequences, can actually be much worse.
So I saw a lot of nods at that point about how measurement drives action and measurement drives our behavior. And I think that maybe that ties in a little bit to the next question, which I'm going to direct at Dr. Downey as the first respondent, which is, do you believe that we can achieve the change we need with the institutions that we have right now? And why or why not?
Yeah, thanks, Meredith. I also was thinking that was a good segue into this question. Well, I have to be hopeful because that's the work that I do, and I think generally I'm a cup half full kind of person. Although when I look back over some experiences, I also think I've been a little this side of delusional sometimes. But I think, and I'm focusing on education in a health science context right now, because that's the work that I'm doing in addition to my research, which is looking at the perspective of Indigenous women who have experienced heart illness or stroke, and with a focus on educating healthcare practitioners to work in a more culturally relevant and culturally safe way with that population. But I do believe it is possible to achieve the changes we need within the institutions. We have, again, I have to situate that within a reconciliation framework that is inclusive, as mentioned, of both decolonizing and indigenizing strategies. But we also need the practical as well. We need, a holistic vision that is supported by senior policy and decision makers. So in order to engage in the work that I do, it had to, I had to inform the leads that, the first year would be about relationship building and education. And that takes time, and it's a huge investment. But in order to get senior leaders on board, I had to have that period where they would commit to education, so that they could make informed decisions, so that then faculty level policy could be both developed and implemented. In addition to that, that goes hand in hand with also a commitment to addressing the existing system barriers that are already present and that prevent us from moving forward. And Indigenous peoples, alumni and current existing learners have identified those barriers and an inability to affect change, and have, often reached out to others in social justice movements, both locally and nationally, to try to affect and influence some change. We also have, you can't engage in this kind of work without the assignment of adequate resources. And those conversations are somewhat circular. There's a recognition that the work that we're trying to do does require resources, but who should pay? And there's also a competitive nature within institutions. There's many different networks and different groups vying for a piece of the pie, and whose work is more important. So that's why it's important to put that value and that holistic vision up front, so that it is a whole of institution vision as opposed to a special interest group. And in this case, the training also of clinical practitioners is critical. So we recognize that in this work that many cohorts have graduated and are practicing and have not had an educational background on Indigenous health and issues. And, so it becomes important to enlist them, because they hold power and influence, that is looked to, that is included in decision making. Also, the recognition and facilitation of access to Indigenous traditional healing, Indigenous knowledge. Our people, First Nations, Inuit, and Métis peoples in this country have been asking for this, for inclusion of their own ways of knowing into the healthcare process. And that's been documented in many other reports over time, and more recently in the Truth and Reconciliation Commission in their final report. And organizations and systems have to commit to designing and implementing policies, procedures, and programs that are anti-racist and decolonizing in order to address racism within their healthcare settings, because the resistance that one can experience because of systemic racism impedes, any inclusive process, any equity process that you're trying to achieve. And finally, tools are needed to provide policymakers with mechanisms to affect that change. And often, in my experience, I find that this is the part that's most important to policymakers, is how do we do this? And they are seeking quick fixes in some cases to affect that change. And so, for example, I've been working with a group we're finalizing an article about our process to review and adapt a clinical admissions assessment tool, which was designed to use a critical lens of health equity. But when I had an opportunity to look at this, it did not include an Indigenous perspective. And so we've been adapting that and like I said, doing the final tweaks on an article. But this was to allow administrators and frontline clinical workers to engage in an admission process and use a health equity assessment tool from that Indigenous perspective. And so that's an example of some of the tools that are needed at that policy level. So I'll stop there.
Does anyone else have any thoughts on whether our existing institutions are sufficient or possible to achieve change? Or we can go, the last two questions I think are the most exciting questions. So maybe we'll move on to those. And I'm not going to direct these next two questions at any panelist in particular. So please feel free to jump in. I feel like you are likely to all have thoughts on these last two questions. So first, what work have you done or what work have you seen that's really setting the foundation for more radical change?
I'll jump in really quickly. This is something I've already mentioned, but I'll just put a plug in for the next Toronto Board of Health meeting, which is happening on December 6th, where you will hear from the folks who've done it about how community partnership happened and how well it's happened and what their evaluation is. I think there is really a lot to be learned from this process, imperfect, still in development, but something there, and something that I think won't go away post-COVID, that will be, part of moving toward a new way of doing things that really is driven by and for communities. And that has the potential to be really transformative also by linking together community services, municipal services, healthcare systems, and public health in a way that is really localized at that neighborhood level. I think there's really something transformative and important there. And for all of you who are researchers or trainees becoming researchers, this is so underrepresented in the literature, the work that community organizations are doing. So I'll just put in a plea that you pay attention to this and think about this as you develop your own research plans and agendas going forward.
I mean, I don't know if this is a foundation for more radical change, but I guess it warms my cold, cynical heart to see so many people not just interested in public health, but appreciating what it is that we say we do here. Right? That, yes, a lot of people think we're just a bunch of nags, but at the same time, they start to see that there's, the public health, there's public health in everything. I think it's going to take a lot of political will that I'm not sure is totally present in many countries, but political will to capture this moment and to invest in public health and local public health departments in particular. I mean, I think we often talk about sometimes those sort of national level policies, but like realistically, the people who are informing, talking to the state government or to the city government or to the whatever it is about, the ones that were doing that, to talk about lockdown measures or masking or whatever, that's happening well below the federal level. And so I would hope that this is setting a path for change. I am concerned about the backlash that so many public health officials have faced. I mean, certainly in the United States, it's been an enormous issue. But it doesn't seem to be. I mean, I'm based in a school of public health, and it certainly did not affect our admissions in the last year, and I don't think it's going to affect our admissions next year. There are like just record numbers of people who want to learn about public health and want to get trained and want to go out and do the work, and that's somewhat reassuring, I guess I would say. And I certainly think that they're coming in more radical than I think people were before. Thinking about climate change and thinking about dismantling these systems and things like that. So I guess that's somewhat reassuring.
And finally, to come back to our plane metaphor, or rebuilding the plane while we fly, what changes would you want to see if we could throw out the whole darn plane?
I'll just use this opportunity to shout out and give tremendous thanks to the two Indigenous scholars who are on this panel, and to the Indigenous communities who have shown such leadership in how to take a different approach, and how to do that systematically, respectfully, safely, ethically, and so on, in a way that is not always intended to educate and lead others, but has that effect. And there's a lot, I think, that those of us working in community health and equity in more broadly have learned from that and need to acknowledge and support. So that's the kind of thing I want to see going forward, is more recognition of that work, more learning from that work, and more, where appropriate, applying lessons from that work together in order to improve health, buy-in for Indigenous people and buy-in for other populations.
Thanks so much for those words, and I think that like from my perspective as someone, like I'm an epidemiologist, I'm an Indigenous epidemiologist, so I still feel like I'm not like in the radical spaces or throwing out the whole darn plane. And so I look to those who are on the front lines of the fight against climate change and fight for clean drinking water, and these things like that really are tone setting, and the young people, like the youth, who are really taking that connection with land and making it very meaningful in terms of protecting the earth, and realigning the way we see wellness, I guess, and as something that is connected to each other, connected to the land, connected to generations past and present and future. And I think so. Some of the times when we've been talking about, like, I'm really excited to hear about this, Kate, like the what's happening in Toronto, and I'm thinking about, like, how would that connect to some of the, like, Northern Ontario communities, right, where there aren't a lot of systems to coordinate and structures to coordinate. It's sort of like a very different scenario. So, like, I think we all need to move in our own ways, and look to each other for guidance, and for not necessarily like direct collaboration all the time, but like there's alliances, and I think we can learn from each other as we rebuild. There is a period of rebuilding. One of the things during the COVID, throughout the COVID pandemic, we've been getting information to First Nations leadership in Ontario through weekly reports. How many people have been tested? How many people are testing positive? How many people have been vaccinated? And when one of the people who works at Chiefs of Ontario, who coordinate the affairs for the 133 First Nations in Ontario, said that what's happening to get that information to where it needs to go is an overnight success, 10 years in the making, because for 10 years we've been working on those data governance agreements, honoring the sovereignty, figuring out how the data would be governed and how it would get to where it needed to go, not knowing we were preparing for the COVID-19 pandemic. So these things, it takes time and it takes effort, and hopefully we'll have another overnight success 10 years in the making, 20 years from now. But that, not wishing another pandemic on us. I shouldn't even say things like this, but just, we really need to do the work now, because it's important to lay that strong foundation. Over. I'm taking that from you, Danielle.
Bernice, you put some great wisdom in the chat, and I'm conscious that sometimes folks are listening to these types of panels while they're doing something else, and they might have missed those comments. So I wonder if you'd like to speak to that.
Oh yes, I just wanted to say thank you to Kate for her acknowledgement, and in that regard, well, first I said I wouldn't want to throw out the whole plane because, we have, learned from lessons past and successes too along the way. We can continue to build on them. Like Jennifer was saying, 10 years of working on data sovereignty agreements. There are some things that didn't work, but you wouldn't want to throw the whole thing out. But I also was grateful for Kate's comments, and I'm always proud when I, hear teachings from our elders who acknowledge that, there's 4 races, and, we all make important contributions to the work at hand, and that Indigenous ways of knowing are often applicable to anyone, to all nations. And so I'm always very proud when I hear that, and I see evidence of it in our policies. I think back to the early days of health promotion, and the health promotion wheel is actually a medicine wheel symbol. And, that was over 40 years ago. So, Indigenous peoples have been at the tables for a long time, and often are not given credit for that. So I appreciate those comments.
I think that that's a great place to leave it. So thank you all so much for your time and your energy and your wisdom this afternoon. And thank you to the organizing committee, especially for these great questions. So it was Tatiana and Tamika and Kara who put together this set of questions, which I think worked really well to help engage us in conversation this afternoon. So thank you very much, everybody.
Thank you, everybody. I learned a lot, so I'm very glad that you invited me and allowed me to talk, but
Thank you, everybody. Thank you for this wonderful panel. We just really had an amazing time. I'm amazed. This was a great point to end the 2021 New Frontiers Health Policy Graduate Student Conference. On behalf of our co-chair, Tamika, the organizing committee, Alex, Latin, Kara, and myself, we want to thank the panelists and Dr. Vanstone for this panel. We really enjoyed the discussion. Also, we want to thank Julia and Sherry for all the support, as well as the presenters and attendees of this new edition of New Frontiers for Health Policy. Thank you so much for your attention. That is a wrap for this year, and we hope to see you in 2022 as well. So thank you very much. Have a good day. Thank you.